20th or 21st or around 21st, we do have a function in the India Habitat Center where all of us meet, interact, discuss about dementia, in particular Alzheimer's. But as it is said, change is the only constant in life. This year, we've had to change. We have now this virtual way of meeting. And believe me, the virtual way of meeting can be as enriching as the physically interactive way of meeting at the Habitat Center. So I hope in today's program, we take back with us much more than what we have got in our previous years. And we make this interactive session without really having to go out from our homes in the traffic, etc. At the outset, I'd like to thank my team in the Alzheimer's Related Disease Society of India Delhi chapter. The Delhi chapter has, a long history, and the founder member here is Dr. Vinod Kumar. He, along with the team now, Renu ji, Beena ji, Veena ji, Reva ji, YP Singh ji, Colonel Khanna, who else have I left out? All of us have been, Narendra ji, of course, from the national chapter. So, we have been kind of trying to help in a little way people with Alzheimer's through a helpline service, through counseling, through home visits of the volunteers, through, having meetings in the residents' welfare associations about cognition and dementia. And we have a daycare center and a chronic care facility. Unfortunately, because of the COVID, we've had to shut down the daycare center because of restrictions and, fear of, affecting the elderly who come to our daycare center. And as soon as the COVID is over, we hope to get back on our feet again. The helpline addresses all caregivers' issues who want, to know about how to manage their patients. And along with the helpline, we have, two manuals. The caregiver manual, which we give out to the caregiver to support their knowledge about the condition. And we also have a training manual. We also give free medicines to poor patients, those who cannot afford. So we seek donations from people who can donate for this cause. And of course, we want to do many things, provided, the funding is there. So I think with this, I'd request Narendra ji to share our newsletter and inaugurate our newsletter, which has been kindly put together by Veena ji and the team. Narendra ji, you can share our newsletter. Is Narendra ji able to hear me?
Yeah, just a second. So are you able to see the newsletter now?
Hello. So while he's sharing it, please put your questions to the talks in the chat box. And this is our dementia news for this session. So you can see here, can you go to the first page? I just want to show the cartoon on the first page. So as you can see here, just hold there, please. So I'll be talking about this aspect. You would note that prevention of Alzheimer's or any of the dementias is going to be a lifestyle change. Unfortunately, in the human psyche, we have this, psyche about addressing every disease with pills and surgery. But here in dementia, it's going to be lifestyle, which we focus on. Next, so we have done online consultations. Next, please. You can scroll, Narendra ji. So online consultations in the time of COVID. You can carry on, please. So we are going virtual even in consultations. And of course, the theme of this year's Alzheimer's Day is let's talk about dementia. We've a few of the brain exercises which should be done for people with dementia in this. So you all can go through this, and if all of you send us your emails, Narendraji, I request you to put up our email on the chat box so everybody can send us their emails and we can email them this newsletter.
Sure.
So please, Narendraji, on the chat box, you can put the Dementia Alzheimer Society Delhi chapter's email,
Sure,
so that people who are attending can get this newsletter. And of course, here is Dr. Vinod Kumar, who's so knowledgeable, and he's going to talk to us about how to live well in old age and prevent dementia. So this is that part of it. Next, we can carry on. Yes, please go on, Narendraji. And of course, a little bit about, where to read about dementia and what's significant in the world of dementia, and any new news about dementia. So that has also been covered. You can carry on, Narendraji, just scroll down. So we request you all to go through this, and at the end we have our helpline. So I would request all of you to send your email to the ARDSI Delhi chapter email. Do we have an email on this newsletter? Please scroll to the bottom.
no.
Narendraji, please put the email on the chat box right now, because I can see some people are actually writing their emails there. It will be difficult for us to collect individual emails. So I request all of you to email us on the Delhi chapter email address. With this, I'd, normally there's a bouquet of flowers, and well, I'm making a mental picture of the bouquet of flowers, which Renuji gives me every year. So, so I'm going to start my talk. Thank you all for coming. We are 50 of us now, and I'll start my, screen share now. So if the host can please, not disable my screen sharing. I need to be enabled in screen sharing. Narendraji, please enable my screen sharing. Hello?
Yes, ma'am, I am doing that.
It's still disabled, so I need you to enable my screen sharing. It's still disabled. Okay, so now it's enabled. Okay, no. Still disabled, Narendraji. Narendraji?
Yeah.
I'm unable to share because it says your screen sharing has been disabled. Have you enabled it?
Yes, yes.
Okay. It still says the host is disabled participant screen sharing.
No, now it is there. It is shared.
Okay. Let's hope I can share it. So I've been asked, to talk about what are the implications of having a cognitive decline. And yes, so you can mute all the other participants, Narendraji, except me. So I'll be talking, very briefly on over a period of 20 minutes, which starts now, on the implications of cognitive decline. And so first, what is this cognition that we are talking about? See, normally we are very aware of the function of the hand, the function of our nose, the function of our eyes, the function of our legs, and every part of our body. But there are certain functions of our brain which we are not aware of fully. So for that, the functions of the brain which we really need to be careful about is, of course, memory, how we remember, and of course, how we think, how we understand, how we perceive, how we are able to listen and understand, how we are able to read and understand, how we are able to understand complex, situations, judgments, how do we decide and plan something, how do we execute that? So suppose there is a marriage in the house, how do we plan for that marriage or birthday party, and how do we kind of execute it? How do we calculate in our mind when we go to a shop and purchase things? How do we interact with people? Our personality when we interact with people, our personality in the society, something which is known as social cognition. So these are all, domains of the function of the brain. Essentially, the function of the brain is something which differentiates, a human brain function differentiates us, say, from the function of a monkey brain. So you wouldn't want to turn, out to have a monkey kind of brain, which is impulsive and not knowing what to do and doing funny things. So the function of the brain, all these functions which I just enumerated, is what is cognition. So today's talk is going to be about how we are going to tackle this cognition issues at old age. And does cognition decline? Now, just as we age, our skin develops wrinkles, our eyesight weakens, okay? Our walking style changes, our gait changes. Similarly, the brain also undergoes a change. And this is what is known as cognitive decline. And once it reaches a significant proportion, it gets to be dementia. Currently, about every 7 seconds, okay, there is one new case of dementia. Every 7 seconds as we talk, there's going to be one person who's going to be developing a major cognitive decline. And the numbers are huge. It's huge because we are aging successfully because of, good medical facilities. And as you can see here, when you compare it to say 1990 to 2020, now in 1990, 1 in 20 or 1 in 25 had cognitive decline in India. But now it's 1 in 8, so it's gone up. So as we are aging, as we are successfully increasing in age, the cognitive decline is also increasing in terms of its prevalence and burden. Now, particularly in dementia is Alzheimer's dementia. And this dementia is, a very complex disease. Alzheimer's dementia, which is what our society stands for, but of course we help all other kinds of dementias also. Now, dementia is an umbrella term for various etiologies. So, Alzheimer's is the most prominent of them, and we'll discuss the others also. So, it's a very complex disease, and, scientists are still understanding what is to be done and what is not to be done. And what exactly is causing it, what are the triggers. And accordingly, we are still kind of, learning about this disease day by day and bit by bit. But grossly what happens is, if this is the normal brain, in a dementia of 3 to 4 years, there is a shrinkage of the brain. So the size of the brain kind of wrinkles out, it shrinks. And the vital areas of the brain, which are the memory centers, they also undergo shrinkage. Now, I have put this lady with the gun here. So for every dementia, there are two main causes, okay? One is non-modifiable. Non-modifiable is genes and age. We cannot change the fact that we are aging, and we also cannot change our genes as of now. Maybe later on with some, science advancements, we will be able to kind of modify our genes. But as of now, we cannot change our genes which predispose us to dementia. But we have a choice. And that choice is a trigger for the loaded gun of genetics. So if we have a genetic predisposition, there is going to be a loaded gun, which is the genetic predisposition. And apart from that, the aging, that is the loaded gun. The trigger of which is us. And that trigger is our style, which is our choice. So the trigger of that gun, which is the loaded gun predisposing us to dementia of genetics and increasing age, is a choice we have, and that choice is our lifestyle. And that's why, a little bit of, GIF image which I put of a loaded gun. Now what happens in dementia? So basically you have to remember there are ABCs in dementia. And these are the ABCs. A is, activities of daily living, that is functional. So the activities of daily living will come down. B is the behavior. The behavior and the personality will change. The family members will say, he is no more the same or she is no more the same. There is a change from before in the 60-year-old gentleman who's my father or mother. And there's a change from before in the personality of what I knew as a youngster or a kid. So apart from a decline in the activities, whether it's, remembering, whether it's reading, writing, or physical activities, or, daily activities like doing a puja or doing some, ritual which they do every day, there's a change in those activities. There's a change in, personality and behavior. That is the B. And C is the change in the cognition, which is what I told you. So there's a gradual erasing of memories. There's a gradual, and sometimes it can be sudden also. And there's a gradual, fall out of reading, understanding, judging. So all that starts, kind of falling out. So the ABCs is what starts falling out. Now, apart from that, what is most disturbing to the family? What is most disturbing to the family is the fact that there are behavioral and psychological symptoms, which are the ones which often bring or which kind of unmask the cognitive complaints, because not many people pay attention to memory or, language or reading, writing. But the moment the elderly person starts behaving aggressive or wandering or showing a pathetic, withdrawn behavior, or starts crying easily, or has inappropriate behavior, or starts shouting, or starts becoming aggressive, that's when the family members come to us. Now, unfortunately, it may be too late by then, because the behavior has brought it to the notice that this person, elderly person, has changed. But actually what may have changed before is the mild memory, the mild, understanding, the mild change in personality, the mild not being the same before. And then later on, in the later stages, they start hallucinating, they start having delusions, they may be suspicious that somebody's trying to kill them. So all these are things which come up. And how it happens is in Alzheimer's, it's a gradual shift. It's not sudden. But there are certain dementias where it can be sudden. So generally in Alzheimer's, it's a gradually relentless progression. Unless people come to us early, unless we intervene early, unless we preempt this gradual decline by our lifestyle change. So generally, I told you, Alzheimer's is a diagnosis we come to after ruling out all possibilities. We do, blood tests, we do serum B12, we do thyroids, we do vitamin D levels, we do, certain other markers in the blood. We rule out strokes. If there are underlying strokes, that can cause dementia. So, we rule out other causes of dementia. There's so many degenerative causes like frontotemporal, Parkinson's with dementia. So then we come to a diagnosis of what kind of dementia it is. Now, there are stages. Each dementia has stages, okay? And there's an early stage, there's a middle stage, and there's a late stage. We as clinicians, I as a clinician, want to pick it up in the early stage. I don't want to pick up a patient in the late stage when they're already on the bed and they're passing urine in clothes. I don't want that happening. I want to pick up the mild memory, the mild language, the mild understanding, the mild execution, so that I'm able to work with intervention strategies for it. Why are we talking about this? Because this is a delicate balance. It's a very delicate balance to give you a benefit, or to give the elderly person a benefit of early intervention versus the risks and the hazards and the implications of later intervention. There's a lot of awareness we need. So the society does that. Believe me, we have a completely academic and voluntary society. All our volunteers do selfless service, not a penny charge. So there's awareness to be generated for which we work. We arrive at a diagnosis at the memory clinic at AIIMS, RML, and then we manage and care, and of course, end-of-life care, which is never discussed in our country, whether it's the living will or whether it's, advanced directives to our family members, and we can discuss this in the discussion session. In Western countries, there are living wills and there are advanced directives. Unfortunately, our elderly are not in the habit of having living wills or advanced directives, and this is something hugely lacking in our country. So the implication is huge here, particularly of what autonomy the patient is going to have if they're in the last stage where they're not going to improve. Very often the implication comes in the educated class as well as in the uneducated on what is to be done because the person has forgotten ultimately to sign. They would forget writing, they would forget reading. So the problem, which is really huge, is that they have bank accounts, they have money, they are well-to-do or they may be poor, but eventually, because of the cognitive loss, they have forgotten to read and write. And so there's an issue with signing. Now, this is a huge issue. This is an implication. That's why I say that we should be in the habit of advanced directives to our family and living wills so that we are able to know that, and what is to be done with the signature is to be done right in the beginning, in the mild stage of the disease. So this is an implication which has a huge bearing on the care of the person as well as the caregivers, thing. So then of course is that fact that it has huge implications in terms of progression. If we detect it early, if we detect the disease in the pre-mild cognitive impairment, which is a scientific term, I don't want to confuse you with it, then, we can start certain medications which prevent the patient progressing to the severe form of the disease. Okay, so this is done by memory tests, which are neuropsychologists. We have very good neuropsychologists, Dr. Ashima, who's spoken on this forum before. We have excellent tests now for our Indian setting. We do them and we try to make out is it early or moderate or mid. And then we try to intervene in the early phase so that it doesn't progress to the dependency stage. Then, of course, the implication is to the caregiver. There's a huge implication for the caregiver. For the caregiver, it is no more a 24-hour day. The day gets converted into more than 24 hours because that's the amount of effort and work the caregiver has to give to the patient. So it essentially becomes, I would encourage all of you whose family member has the condition to read this book, The 36-Hour Day. This will tell you how to deal with and how to understand the problem of caregiving, how to distribute caregiver burden. So the caregiver has to manage medically, remember the medicines, remember the times, which medicine is doing what, which one to increase today, which one to decrease today. And the caregiver has to look at all aspects, the activities. They must be able to report to the doctor how the activities have improved or deteriorated. They must be able to report to the doctor how the behavior has changed, has it improved? Does the doctor behavior medicines or do some non-pharmacological strategies of suggesting behavior changes? And of course, the cognition, does the doctor need to work on medicines for cognition or intervention strategies for cognition, which we do at our daycare center. So, cost of illness, there's a huge, the other implication is the cost of illness. There are intangible costs. Intangible costs are, of course, the caregiver who's sitting with the patient, the cost involved in that the person is no more able to work, is not able to go out and do anything. And there are societal cost because it increases the burden on the community and the society. If you've not got insurance, or if you've, insurance doesn't cover dementia always. And of course, there are intangible and tangible costs, which are a huge other implication apart from caregiver burden, the cost issues, the signing issues, of course, and it turns your world topsy-turvy. It turns everything up and down, and of the implications of cognitive decline, which we must be aware of, and hence we must approach aging appropriately. Now, when we talk to people who have cognitive decline in the early part, this is what they say. They want a person, and even we want a person-centered care. That is why we emphasize that the caregiver be educated so that we are able to give an appropriate care. And the patient in the early stages will tell us that I want certain personal choices, I want certain services, I want certain support systems. The family member says, I want certain support systems. So really you're needing to expand more than the normal aging. You are no more in the normal aging concept of going for a morning walk, coming back and having your breakfast, listening to something relaxing. You're no more there. That window is out. You move to a window where you need support from all aspects, whether it's the community, society you live in, from the caregiver, from the doctor, from a volunteer. So you really become much more dependent on so many more people. And that's why we need to build up this community at the ARDSI daily chapter. The other thing is we need to train caregivers on communication charts, decision-making profiles, and I'll just throw an example out there. So a person with dementia is suddenly putting her clothes in her has to know intuitively that maybe she's thirsty and offer a drink. And suddenly a person with dementia is sitting and there's no upstairs, there's no staircase, the house doesn't have a staircase, but suddenly she will say, I want to go upstairs. So intuitively, the caregiver has to think maybe she wants to go to the toilet, lead her to the toilet. So these are interventions which we have to teach our caregivers. So there's a huge amount of time the caregiver has to invest. Going to the bathroom, instead of going to the bathroom, she backs away from the door with fright. Why? Because, you know, you can imagine, all of us have memories. For example, there's a door behind me. I know, because of my normal memory, what lies beyond that door. But for a person with dementia, loss of memory, they don't know what's lying behind that door. It could be, they could be imagining that there is a huge hole there into which they're going to fall. So they're afraid of even opening the door and going out. So there's fear, there's anxiety. So a caregiver needs to be educated as to why the person is having that anxiety or fear, because they have no memories of what lies beyond that wall or beyond that door because of the memory impact. Sometimes a person with dementia may just pull the clothes out and disrobe, and actually they may be cold or warm. So they, you know, these are things which you need. Sometimes they may just walk pulling their hair, and you know, it's scary to the caregiver. And all they may be wanting to communicate to you is that they want to go to bed. So essentially, a person with cognitive decline and major cognitive decline, which is dementia, becomes a little kid. And you really have to understand from gestures and triggers of what brought on that behavior, what the solution could be. And these are things which the caregiver needs to learn. So there's a huge implication for the caregiver in understanding. Then there comes a thing that, you know, the person may not be able to use the straw, use the because there's apraxia, they may not be able to go to the shop. So again, there are a lot of intervention strategies which the caregiver needs to be taught about, their implications to the caregiver giving time onto this. And then, of course, there are people who have to meet together once in a while and discuss various issues. Is this strategy working? Is this progress good? Is it important to the person? Is it a, you know, as I said, person-centered approach. It has to be centered onto that person, not to the caregiver. Of course, we need to tackle the caregiver's burden. So there's a huge implication on caregiver burden, caregiver stress, caregiver depression. All those things will come up. And this is, of course, from our center. You would recognize who she is. We should be able to provide awareness to prevent all this happening. We should be able to address these issues in the community. That's what the ARDSI Delhi chapter does. We should be able to tackle stigmas. Sometimes people don't want to tell that they have memory complaints. They think it's a stigma, which is really huge, and it forms a roadblock and a barrier to care and early diagnosis. Narendraji, is my time up?
Yeah, a couple of minutes more. Hello.
Okay, that is possible. Okay, and whatever decision we take as a doctor or as a community has to be a positive decision so that there is an improvement in the quality of life. Now, I'd like to end by saying that we all need to, right from our young age, right from this age, work on our cognitive reserve. You know, we think about our bank reserve, we think about so many things, you know, what reserves we have in our family, in our workspace, but we need to work as an individual on our cognitive reserve. So what exactly is cognitive reserve? The cognitive reserve is basically the ability of the brain to resist any disease by modifiable life experiences. Remember the trigger? That's the choice. That's a modifiable life experience. And so that we don't go, we can, you know, push back dementia. We can stave dementia by 5 to 10 years, which itself is a huge effect. And there's several modifiable things. Do not smoke, do not take alcohol, eat healthy, eat nutritious, you know, your dals and lentils, etc. Eat your, take olive the polyunsaturated oils. Take walnuts, take greens, take nuts, go out for walks, do yoga, do aerobics if you can, if your physical strength allows you. Check your blood pressure. Avoid sugars. Sugars are really harmful after the age of 30. People skew their diets. There's too much protein, or too much protein is also bad. So eat little. There is this concept of intermittent fasting, that eat in an 8-hour or a 6-hour window in that 24 hours. That's going to be good for your brain. So intermittent fasting, but eat in that everything in a balanced way. Eat your traditional stuff. Eat your turmeric. Have your, whatever herbs you want. So basically, these are the modifiable. And this is just to show you our chronic care facility and daycare center. So these are our patients who are made to do various, activities in the daycare center. Avoid sitting on the couch for long. Avoid watching television for long. And keep your mind involved in all kind of brain games, whether it's puzzles, whether it's Sudoku, whether it's, logic, or, and this concept that I'm going to do this at 50 and not before that is wrong, because cognitive aging, or the decline in cognitive reserve, starts right in the beginning. The day you are born, you start aging, physically also as well as cognitively also. So really your cognitive decline starts the day you're born. Of course, in the first 15 years of life, there is a gain. And after that, there is a decline, which you really need to look after by working on those triggers, which are your modifiable lifestyle choices. And the diet, of course, the best diet is the MIND diet. For those who don't eat non-veg, it's okay. You can supplement it by taking, your soy protein. You can supplement it by avocados or by nuts. And, occasional wine is okay, but no alcohol, and drink a lot of water. So basically a MIND diet is going to be good for you. And please look at your food labels. Don't go in for food which is coming in packets and processed food. That's really going to be harmful. Avoid obesity, avoid sedentary lifestyle. And of course, too much of sitting in front of the computer. Look back at your traditional systems. There are many good things in our traditional systems which we often don't talk about. Physical exercise is exercise for the brain. So you've got to do it to not lose your cognitive reserve. Do physical exercise. It improves cerebral perfusion, it improves emotions and mood, and do it every day religiously. Do yoga, do meditation, and of course have a purpose in life. It's very important. It has been shown that people with increasing age, if they have a purpose in life, they stave off dementia. Always have a purpose in life. What are you going to do with your life? Even though you may have retired from work, there has to be something. Be active in your community, do something positive, go in for charity, or go in for opening a small center where you can do candle making, or anything, a boutique or whatever. So keep your mind active by having a purpose in life. Stay motivated, be involved positively. Be less neurotic. You should not be neurotic, because neurotic personalities are more prone for cognitive decline. A negative personality is more prone for cognitive decline. And of course, talk about preserving cognitive health in your community, in your family where there are elderly people. Unless we discuss these issues, they are not going to be tackled. Unless we start talking about it, so that we are not disabled when we are old. As I said, the cognitive loss is just the epiphenomenon. The roots are deep. The roots are deep, and the roots need to be nourished. The nourishment is going to be by exercise, by not having toxic thoughts, by not having repeated trauma, whether it's toxic trauma, physical, emotional, spiritual, whatever, and be a spiritual person, have good sleep, improve your relationships. All this goes a long way in nourishing the roots to prevent cognitive decline and promote cognitive reserves, so that we can push off. We can just remain in the pre. We don't want to see people developing dementia. And believe me, the Western countries have actually reduced their burden of dementia by implementing these changes. And we have to start, so that we can serve the healthcare needs of the elderly in our family, community, and society, along with the ARDSI Delhi chapter. Thank you.